think yeah, we can gonna start. And before we start, I want to introduce our speaker today, our old friend Dr. Vasiliki. She is qualified from AUTH Greece, and her clinical interests include canine and feline gastroenterology, nutrition, and diagnostic, interventional endoscopy. And she also holds a GP cert in small animal internal medicine and a GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate, and also a PG cert in small animal medicine from Harper Adams University in UK. And she also is the invited speaker in multiple seminars, webinars, and a trainer in gastroenterology and endoscopy courses in Europe, Middle East, Africa, and Turkey. And she also awarded by AAFCO. Okay, so this is our speaker. So it's your time. I will give you the host. You can share the
Yes,
screen.
so that I can share screen.
Yeah.
Hello, everyone. I'm very excited to, okay, let me just share screen first, and then we can talk.
Yeah, we can see it.
Yes, and you can see it in a presentation mode, correct?
Yes.
Good. Hello, everyone. I'm very excited for today. We're going to split the lower respiratory endoscopy into two parts. The first part will be the introductory for those of you who are beginners, and the second part will be the more interventional ones. I will try maybe next time to have an accompanying speaker that does more procedures in tracheal stenting that I do, so that he can explain step by step as well. So today we're going to go through which endoscopy equipment we should have, the procedures, some techniques in order to have our sample collections, because I know that many of you already do endoscopies, and lower respiratory endoscopy actually is one of the most, not dangerous ones, but I should say that it's one of the endoscopies that you should definitely have people and nurses to be incorporated in your team, because you will need help. So I would definitely want you to put some messages in the chat box so that I can know if you're a beginner, if you already do endoscopic procedures, and you might as well bring your cases. We can talk about them. And last week, actually, I had an amazing experience with an international group of endoscopists, and we bronchoscoped chimps. And the next case that Auha will upload will be a very, very interesting case of a leopard. So yes, I mostly do cats and dogs, but we have some, extraordinary cases sometimes, and you may visit. I think that it will be uploaded during the next month, the leopard case, and you will have the chance to see, for those of you who are into wildlife and exotics as well. So why tracheobronchoscopy? There are a lot of cases that are admitted to our clinic with chronic cough, and they visit first the cardiologist. And it has been proven nowadays, and I really want you to highlight that, and I really want you to remember that many of my cardiologist friends nowadays say that we used to think that cardiac enlargement in patients that have cardiac failure, for example, would give a consistent and chronic cough, which has been disputed over the last year. And it seems that most of the cases that are coughing are actually primarily it is a primarily lung disease, respiratory disease, and not a cardiac one. Of course, if you have a geriatric patient and you need to distinguish the cardiac from respiratory causes of cough, then he will have a visit to the cardiologist, and then he will come to us for further investigation, to the internal medicine team for further investigation. But keep in mind that most of the times that dogs and cats are coughing, for cats, it's most definite that cardiac origins of cough are more rare or none. So most of the times that a dog or a cat is coughing, then it has a pulmonary, lower or an upper respiratory disease. Okay. So to distinguish the cardiac from respiratory causes, every time we have some radiographic lesions of lung disease or of tracheal disease, chronic alveolar or bronchial patterns, most of the times these are indications to do a tracheobronchoscopy, and especially a lower bronchoscopic procedure, a lower respiratory endoscopic procedure, to collect samples, because we need the samples to differentiate the disease. Otherwise, we would have differentiated it from the imaging that we have, but we can't. So we have to take samples, either cytology samples or biopsy samples nowadays. And I want you to write down in the chat box who of you who are scoping are taking biopsies from the lungs. And I will tell you later on why we need to take biopsies from the lungs. I've done it as a standard procedure, but I know that a lot of endoscopies are a bit scared about that, about the bleeding that we have afterwards. But we're going to talk about that and discuss it. Endoscopy guided BAL. Of course, you can do a blind BAL, and next time we will talk about the steps of the BAL. But it's even better to do an endoscopy guided one, because you can go to the lesions and flush the lesions and take the BAL, the bronchoalveolar lavage, from the space and the bronchi of the lesions, where the lesions lie. And of course, we have other causes, other indications for tracheobronchoscopy, like the interventional ones, where we put tracheal and bronchial stents, where we can have balloon dilations for tracheal stenosis. And when do I have tracheal stenosis? When it is congenital, but also when my ET tube procedure, something has gone wrong with my ET tube procedure, and I have a trauma, a tracheal trauma, and then I have, for example, tracheal stenosis. Please beware of the traumas that you might cause post-intubation. They might cause tracheal necrosis, and I'm going to show you two cases that we had in my clinic, one with tracheal necrosis and one post-intubation tracheal stenosis in a cat, that we had to actually do balloon dilations. For foreign body retrievals, for laser ablation of tracheal tumors, and of course, sometimes to aid very difficult intubations, especially in brachycephalic breeds or in cats, where the intubation is really, really difficult. And there is a list. Hi to Argentina. Hello to everyone. And thank you, really thank you for your interest in veterinary science. I know that a lot of you are afraid of the biopsies, but we're going to talk about it later on. So indications: acute cough with a suspicion of an inhaled foreign body. We do not scope acute cases. Okay, we mostly scope chronic cases that are refractory to reasonable treatments, to antiparasitic. And here, another thing that I have to highlight, because my background is internal medicine, and of course I do endoscopy, but I always connect endoscopy with the internal medicine. So if you have a coughing puppy, of 2 months old, of 3 months old, try antiparasitic agents, try febendazole. Don't put this puppy onto corticosteroids or anything else, and you will see that there will be, most of the times, there will be an improvement. Chronic cough with no response to common treatment. Before giving cortisone, though, that would be great if you would do your procedures with no medications and with at least 2 weeks from your antimicrobial treatments. Unexplained lung infiltrates. As we said, when we have lesions in the x-rays and we cannot explain them, then we definitely need a cytological evaluation or a BAL evaluation or an histopathological evaluation. A confirmation, the tracheal collapse, if you take x-rays, both inspiratory and expiratory x-rays, then you will definitely, or if you do a CT scan, you will definitely verify your tracheal collapse, but it's totally different to have a diagnostic endoscopy procedure in order to see the length, in order to see the dynamic tracheal collapse, because you might watch it in your x-rays, you might see it as a static image, but it's totally different to see the endoscopic procedure of in order to evaluate the actually grading of the tracheal collapse and also to see the dynamic of it. To see if we have a stridor that is not explained by laryngoscopy findings, because we always do priorly a laryngoscopy. If we have persistent halitosis, if we have hemoptysis, and sometimes these dogs are admitted to our clinic, but with signs of hemoptysis that we misinterpret as hematemesis. So sometimes they actually the blood is coming from the lungs, but we think that it's coming from the stomach, and the referring vets say that we should do, for example, a gastroscopy. So we should be very, very cautious about that. Diagnosis and staging of pulmonary neoplastic diseases, evaluation of other caliber disease like bronchiectasis, for example. And as we said, the degree of airway collapse, not only of tracheal collapse, but we might as well have bronchial collapse. Removal of mucoid plaques. And next time I will show you a lot of mucoid plaques in cats that actually cause a great deal of a problem. And of course, when we suspect that we might have a laceration of some kind. And what are the contraindications? Because as we said, this is a procedure that's riskier than all the other flexible endoscopic procedures. So when we have, for example, an uncorrected bleeding disorder, when we have non-reversible hypoxemia, when we have cardiac arrhythmias, we're not going to scope an unstabilized, an unstable patient, cardiac patient. When we have cardiac failure, for example, and it's not stable, a patient that's not stable. When we have tension pneumothorax or severe pleural effusion, first we have to stabilize the patient, and if it's absolutely needed, then we will proceed into an endoscopy procedure with a very, very good anesthesiologist, a very competent anesthesiologist. And of course, there are some other relative contraindications, which most of the times I actually ignore. But this is what we call scientific neglect, because I have to do the procedure. When we have pleural disease, when we have severe pulmonary parenchymal disease, but I have to, I cannot, strongly highlight that when we have severe parenchymal disease is when the procedure is needed. When we have pulmonary hypertension, uremia, or a primary esophageal disease as a cause of coughing like megaesophagus, or, as I will show you in Irish wolfhounds, when they have a tendency for aspiration pneumonia, or other breeds like brachycephalic breeds that have a tendency for aspiration pneumonia. And what about the complications of the procedure? It has more complications than other endoscopy procedures, and they should be regarded actually as high-risk procedures. There are different publications out there for the complications that we might have later on, not from the sample collection, but from the procedure per se. So in cats, there is a 14% incidence of severe complications and a mortality rate of 6%. And in cats, we really have to be very cautious because bronchoconstriction can actually lead to desaturation, to hemoglobin desaturation, with oxygen and respiratory compromise. This is why we have to monitor during recovery these patients. In dogs, there are no figures published on complication rates, and in humans, mortality rates are reported to 0%, pneumothorax up to 6%. We also have bronchospasm up to 12.3% and bleeding up to 89%. So you see that even in humans, the bleeding rate, because they tend to take biopsies as well in humans, is a bit increased. And when are these complications going to take place? When will I see these complications? When should I expect them? So the desaturation based on the glottis or the bronchospasm usually occurs within several minutes after the procedure on the recovery, on the very short recovery stage. And a tension pneumothorax can develop up to a few hours after the procedure. So these patients are not like the gastroscopy one patients that you can release, that you can give, that they can go home. You have to keep them in-house in the hospital and monitor them at least 6 to 8 hours post the procedures. And anyway, these patients are patients that need oxygenation. These are patients with severe lung disease, lower respiratory disease. So these patients need support after your sampling and your endoscopy procedures. There are other minor complications as well, like induced airway irritation, hypoxemia, fever, and barotrauma, which is not minor, as we said in human patients. This is a complication that we see in many patients, and of course, hemorrhage. And I'm going to show you something, and I want you to really to see what happened here. So I'm going to take a biopsy sample. This is from a dog, and you see that this dog bled before even doing anything, before even taking my biopsy sampling. And I'm going to repeat it once it's finished. From the site of the biopsy, it actually bled less. So this was a patient with liver disease and with increased PTT. So you really have to be cautious in these patients. And I'm just going to show it again. It went in my biopsy forceps, and from the touching of the mucosa, without even causing any major trauma, it started bleeding. So you really have to be cautious about what's happening in the coagulation profile of these patients. And I always do a coagulation profile, even if these patients do not have liver disease. And what about the coughing cut? I do not know if yes. So can we hear the coughing, Jason?
No, I think you need to select share the sound before you share the screen.
Oh, should I do a new share?
Yeah, I think you can share it again and try to find
Uh,
where you can share the sound.
where I can share the sound. Okay.
Yes.
Please leave a message if you didn't hear or if you heard the sound so that I know. So should I go out and reshare the presentation?
Yes, I think you can try it. Yeah,
Let
I
me,
think I don't hear any sound.
you will
Yeah,
hear it now.
nope.
No?
We
Okay,
cannot hear. Yeah,
you cannot hear it.
yeah.
So let me
Can share it
do
again.
a new share. Stop sharing.
Yeah. When you create a share, you
Oh,
can.
no sound. Thank you. Come on.
Yes.
Let me see. And when I share,
There is there's an option that you can share the sound. You select it.
it says leave computer audio
Yes, I think it is. You can try to
because it
select it.
says same as system, speakers, same as system. Leave computer audio.
You can try it and we will see. Yeah, let's see if it has the sound. Um, I still cannot hear. Oh, some people have sound. Okay. But now we cannot hear your sound. You know, it's a Swift. It's Swift. You have choose to share the sound of your computer, but now we cannot hear your voice. Okay, now we can hear your
Now you
voice.
can hear me.
Yes, yes,
Some people have,
yes.
though.
Okay, so let's continue.
Okay, let's continue. I'm
Mhm.
sorry. Okay, I hope that you can all hear me now. What about the coughing cat, which is always a mystery? You know, are they retching? Are they vomiting? Do they have hair balls? Do they have dysphagia? So remember to ask in your clinical history all the signs and clues. For example, if they have open mouth breathing episodes, if they have exercise intolerance, because yes, as Sam Taylor says, cats get it too. They can have exercise intolerance. If they have resting tachypnea, and let's see what I mean by that. This poor guy came to the clinic, and you can see that he has a resting tachypnea on the examination table. What about this one? You see that it coughs and it expels also content. And this is what the owner has actually sent us. But can I really say if a cat has bronchitis or chronic bronchitis or if it has feline asthma just from the pattern of the coughing? No, we can't. And this is why endoscopy comes on the way. You see, sometimes we don't know if they have reverse sneezing or, and it goes with ptyalism. Always in cats, it comes with ptyalism, the coughing. Okay, it's totally different than the dogs. And they have this lip leaking afterwards. And of course, we're not going to go through all these diseases, but when do we have cough? In feline lower respiratory diseases, diseases of the airways, and pulmonary parenchymal diseases, the diseases of the airways, the tracheal disease or the bronchial disease, which are very, very common in cats, are the feline asthma and the chronic bronchitis. And we're going to say how we can distinguish them. And also the infectious causes of that. And the pulmonary parenchymal disease, the bacterial are very, very, the most common of those are the mycoplasma ones, but all the other bacterial infections are not that common in cats and dogs. They are in humans, but not that common. And of course, we have the viral components in cats. And there are some others like the idiopathic pulmonary fibrosis, which is very rare in cats, but it's very common in West Highland White Terrier breeds. So keep that in mind, that in Westies, I always have to keep on looking for pulmonary fibrosis. And of course, we can have pleural space disease from feline infectious peritonitis virus, from chylothorax or pyothorix. And this is from the ISFM and Sam Taylor's lecture, which I really, really liked. And what is feline asthma? The definition of asthma is that we have spontaneous bronchoconstriction. We have eosinophilic, mostly eosinophilic inflammation and hyperresponsiveness. And it only affects cats and people. Dogs, we do not see lesions like that in dogs. And the case that we will upload is a potential leopard asthma that has not been established up to now. And these changes can be progressive, and we can have remodeling. And what is chronic bronchitis? So it's a very common cause of coughing. Is it secondary to another airway insult? Highly probable. In the feline asthma, we have an allergic component. In the chronic bronchitis, we could have another airway insult due to a viral disease, a bacterial disease, or any other kind of primary diseases. Here, we do not have a bronchoconstriction, and this is what differentiates chronic bronchitis from feline asthma. We have an airway narrowing due to mucus and remodeling, but we don't have this acute onset of bronchoconstriction. Okay, most of the times the BAL is neutrophilic. We don't have an increased number of eosinophils, but having said that, in cats, it's really, really difficult to say what percentage of eosinophils is pathological, is abnormal, because they can have in their normal cytological evaluation a high count of eosinophils as well. In chronic bronchitis, we have mucosal edema and excessive mucus production, and there is a more chronic history. And these cases are not the cases that are admitted as an emergency case in your emergency clinics. It can be dyspnoic, the cat can be dyspnoic, but nevertheless, they don't have this acute bronchoconstriction that gives this emergency character to your clinical case. And let's see a bit about the coughing dog. So what do you think? We have to differentiate, we have to localize where the cough is located, is localized. Is it upper respiratory disease, which means stridor, larynx, pharynx, and nasopharynx, for example? Is it tracheal? Is it lower respiratory from the lungs? So this one is more of a tracheal sound. Let's go to the other one. This is very, very subtle, but it shows that it's from the upper respiratory tract, like a reverse sneezing or a tracheal as well. Always, always ask the owners to send you videos. These are all videos that we have from owners. And you can see this is nasopharynx or larynx. And the owner says, are you choking? So these are all indicative of which procedure we should follow. And what about this one? These are all perceived as coughings. This was a reverse sneezing, actually. Okay. And in dogs, there's a huge differentiation list, and I like this one. You will have this one in the slides anyway, because it is based on the actual finding that we have. Sorry, for example, if we have a non-productive cough, what we should think about. If we have a productive cough, what we should think about. If we have hemoptysis, if we have a cough while eating or drinking, which we definitely have to think about laryngeal dysfunction or megaesophagus cases. Okay, and this actually differentiates the cough based on our auscultation as well findings. If we have crackles, if we have wheezes, if we have high-pitched wheezes, for example, in chronic bronchitis cases, if we have dull lung sounds, if we have inspiratory or expiratory effort. So most of the chronic bronchitis cases are expiratory, have expiratory effort. So because we have an intrathoracic airway disease, whenever we see expiratory effort and dyspnea, we always connect it with an intrathoracic disease. And again, we also have a differentiation according to our radiographic findings. Okay, for those of you who cannot hear the sound, I'm going to send the videos with the sound. So when you have the presentation, you will have them with the sound so that you can hear them. Okay. When we have, for example, cranioventral alveolar patterns, and there's an amazing webinar as well of Pete Mundis coming up with an explanation on radiographic lesions. And I urge you to attend that as well, because it will give you a huge perspective on where to scope and when to scope. For more information, you can email me as well, and I will send you all the links of that. When we have cododorsal or interstitial and alveolar pattern, what kind of disease is there? When we have diffuse interstitial pattern, for example, it could be pulmonary edema, could be interstitial pneumonia, could be the idiopathic pulmonary fibrosis. And where I want to stay is something that I've learned from my dear friend Luca Ferenzin, who is a cardiologist, and he was talking about the causes of cough. And this is a cause that we tend to neglect, the postnasal drip syndrome. I don't know if you've ever heard of that, but I recently found out about it. And have you ever seen of these very, very geriatric patients, old patients that have excessive swallowing, and they're sneezing and they're coughing, and we think that something is wrong with their teeth, and maybe this is why they're dripping. They have tears also as well, epiphora. So this is the postnasal drip syndrome, and this is a syndrome that we should be aware of. It's commonly observed in dogs, but very, very poorly described. And it's associated with rhinosinusitis most of the times, or with very poor dental hygiene, the roots of the teeth. And this is a common cause of cough as well, of coughing. And let's go to our patient preparation. As you see, this is a patient that will go into doing rhinoscopy and tracheoscopy. So the positioning is the same. This patient has undergone these two procedures. So we always have a complete history, full physical examination, always both for rhinoscopy and tracheoscopy, a coagulation profile, radiographs and CT scans. And the CT scan should be performed before bronchoscopy because you really want to be guided. And because when you enter with your scope, then you might cause hemorrhages, you might cause lesions that later on might be shown in a CT scan if you do the CT scan after your bronchoscopic procedures. So all these procedures, imaging procedures before your endoscopy procedure. Fasting for 12 hours. The general anesthesia here is mandatory. We have intubation with a cuffed ET tube and mouth gags as well. Our major concern in lower respiratory endoscopy is to prevent hypoxia. And there is an increased danger for cats, as we said, because they have this bronchospasm and toy breed dogs. And I'm going to tell you what we do to prevent that in these breeds and in cats. The endoscope may irritate and traumatize the airway mucosa. And the anesthetics inhibit because all the anesthetics inhibit the normal mucociliary escalator, aggravating any airway disease. So anesthesia, which means that anesthesia actually burdens our already established lower respiratory disease. We always do, especially in places that are endemic, we always do an AngioDetect test. I don't know if you have one. Write in the chat box if you have one, and if you do the AngioDetect test. Always do that before bronchoscopy because you don't want to be in the position that the lungs will be full, will be hemorrhaging to death. Okay, and the patient positioning is sternal recumbency with the head supported by a towel, a rolled tower, or a sandbag, okay, because we want the neck to be a bit extended. And what do we need? We definitely need a pulse oximeter and a capnograph. We need oxygen supply, either with an anesthesia breathing system or at least an ambu bag. And I would urge you to have an anesthesia breathing system. A laryngoscope with an adequate light, not with a poor lighting. Sufficient amount of an induction agent. Why? Because we will not only use the induction agent during the intubation. This is a procedure where we will intubate and extubate many times. So we need induction agent in case the animal starts waking up. So we need to reintroduce to establish a good level of anesthesia. A clean endotracheal tube of the correct size, okay, and maybe one size below, especially in cats when we have bronchoconstriction. In cats, always have, this is a tip that I'm giving you because we have needed it many times. So in cats, please try to have, apart from the ET tube that you already have for your endoscopy, have also one size below, okay? A urinary catheter to pass a spastic glottis, or also for oxygenation, to pass it by the sideways from the endoscope in order to provide oxygen. Ready access to suction equipment and terbutaline because you might have foamy material after the procedure. You might need suction. And at least 2 vets or 1 vet, 1 more vet, and 1 trained nurse, to help you with the extubation and intubation process in order not to cause a trauma. Okay, and this is the checklist. I always have checklists in my procedures, even for my gastroscopy procedure, for any procedure. And this is a checklist that I have taken from Ed Hall. I urge you to use checklists because it has been proven by the World Health Organization that if we, and this has been proven for the surgical checklist, that if we have a pre-operative, during the operation and a post-operative safety checklist, and if we stick by our checklists, then 1/3 of the patients that would die will be saved, which means 33% of your patients that would die if you do your safety checklists will live. So this is a huge percentage of cases. We tend now to actually stand by what we call SOPs. SOPs are standard operating procedures in every procedure that we do, because this way we can monitor our procedure. Okay, so always keep which staff was present, your anesthesiologist, your nurse, which is the leading vet, the procedure that you write down the procedure. This goes for rhinoscopy, for BAL, for tracheobronchoscopy, for any procedure that you're doing. What was the indication for the procedure and why do we need that? Because we definitely, if somebody asks us if we were excused, we were justified to do this procedure, we will always have the proper indication to show them. Okay, what was our airway management plan? Was it an ET tube? Was it a flow by oxygen, for example, or a laryngeal mask? Some people use laryngeal masks instead of endotracheal tubes. So write down what you have used. For example, in many cases in gastroesophageal reflux disease, we have found that people who use laryngeal masks have higher incidence of gastroesophageal reflux disease. So write down everything so that it's documented. Was there a mouth gag in place? Some people put 2 mouth gags. Write that down as well. And always, always be careful with the mouth gags in cats, because they might be blind if you overextend your mouth gag after the procedure. You might have blindness after the procedure. Always check for throat pad for endoscopy. This is for another procedure. Will the scope fit through your ET tube? If you have a large breed patient or a giant breed patient, then your scope might go, scope might go through the ET tube. But of course, this gives you the disadvantage of missing one part of the trachea, of examining the trachea. Okay. And this goes on and on. There's a list. You will have this list. Is your anesthetist happy to go into the procedure? And please have this discussion with your anesthetist. And if he's not, he has to write it down. If it's absolutely necessary to go through the procedure, the objection of your anesthetist should be written and marked down. Your plan for recovery as well. And this is your checkout list. Okay, the other one was your check-in list, and this is your checkout list. What was the scope that you used? What ET tube sizes you used throughout the procedure? If you used more than one, for example, were there any unexpected events during the procedure, like the bleeding that I had? Once I proceeded the forceps, I might have hit something. I just touched the mucosa and I had unexpected bleeding. Did I go on with the procedure? Yes, I went on. I took my biopsies even after the bleeding. And I will explain why didn't I take a cytology brush, for example, from this animal, because I knew that this patient had liver disease, because this dog had undergone another bronchoscopic procedure, and they have already taken a sample, a cytology sample, and it wasn't representative. So we really had to know what was going on because he was on multiple antibiotic treatments and it was not responsive. So I sent off an histopathology sample, a tissue sample from the lungs for culture. And the bacterial disease that was discovered was totally different from the cytology cultures that we have taken, because the brush cytology can give us cytology information, but we can also send this brush for culturing, the mucus for culturing, okay? And it was totally different, my histopathological samples from my brush cytology samples. All these concerns should be written down if there's increased concern for glottis edema or spasm, because this will define if your patient will stay in your clinic for many hours of monitoring. Is there increased concern for bronchospasm or pneumothorax? All these should be written down. And this is our recovery checklist. So this is a few minutes after the procedure has finished. And for those of you who do bronchoscopies, I'm really, really interested if you use checklists in your procedures. Please write down in the chat box. So once we are in the recovery, we terminate the administration of the maintenance agent, which is the isoflurane, the sevoflurane. And of course, if we are on induction on propofol, we stop the propofol infusion. Okay, we disconnect the patient from the oxygen source once we see that the oxygen is back on a 98, 99, 97%. Okay, and once we disconnect, then we see if the patient has a normal breathing pattern and rate or not. Is the patient able to remain the oxygen more than 95% on room air? If yes, then we extubate and we repeat the monitoring, and of course we monitor for the next half an hour. We monitor the patient. If no, then we reconnect the oxygen source. Okay. And we try to treat the underlying problem in order to restore the breathing pattern. If the extubated patient is able to maintain the 95% oxygen on room air with normal pattern for 10 minutes, if the patient is able to do that, then we transport the patient to our hospitalization area and we hand it over to a nurse. I always have a nurse over my bronchoscopy patients to monitor them. Okay, otherwise a disaster will happen. And we will not be able to actually monitor it and to see it, because I know that in a hospitalization area, a chaos is created. So we need a nurse on our bronchoscopy patient to see if there is cyanosis, signs of cyanosis, of paradoxical breathing pattern, of dyspnea, of abdominal effort, of vomiting. Okay, so we definitely need a nurse, a dedicated nurse on this patient. Okay, so if, let's say that our patient that we recently extubated cannot keep a normal breathing pattern for the next 10 minutes, then we provide the flow by oxygen, 5 to 10 liters per minute, and we try to find the underlying reason as well. Okay, and if the oxygen is dropping down, then we might even reconsider to re-intubate our patient. If you have any questions, I'm more than happy to answer up to this stage. And I'm more than happy to share what we do in my clinic. And let's have, I talk about what you're having in your clinic, what you do with these patients, high-risk patients. Yes, you will have the presentation. You will have the presentation. And I'm not an anesthesiologist, but we will talk a bit about the anesthetic protocol that we use in bronchoscopic procedures, pre-medication with dexmedetomidine, suitable for dogs, both dogs and cats. Butorphanol is an adjutusive in dogs as well. Pre-treatment with terbutaline. I don't know if you have it as an availability. It reduces the risk of bronchospasm, especially in cats. Especially in cats, terbutaline is a miracle. Is helping. Is very, very helpful for to prevent bronchospasm in cats. ACP and ketamine in cats has been used. You have used it as well. The induction with propofol and alfaxalone, and the maintenance with propofol, alfaxalone to effect, and of course with all our inhaled maintenance anesthetics like Sevo or isoflurane, if the tube, of course, is in place. We always, for the monitoring, we always have an IV catheter. We always check the pulse, the beats per minute. We always have a pulse oximetry. You cannot do a bronchoscopy procedure without a pulse oximeter, and you have to stop the procedure. Sometimes my anesthesiologist is really, I drive her crazy. So she says, get out, withdraw, because she sees that the oxygen is dropping. So if the patient is hypoxic, then we definitely have to stop the procedure, reoxygenate, and then reintubate, reoxygenate for a while, and continue the procedure. And if you see that you have reflex, if you see that you have reflex coughing, then we should dip in the anesthesia, always with caution. Okay. And what about, especially in cats, this article is an open access article. It's an amazing article about the lower respiratory tract endoscopy in cats. These are the agents that we use in cats and the dosages for you to have. You might find them in different textbooks, but I just gathered them all here so that you have everything in one presentation and in one place. Whenever you want to have a procedure, you just go in and see all the steps and the agents used. Okay. And of course, we definitely need some local anesthetic agents that I missed to mention before, like lidocaine and or aerosolized lidocaine, like a spray. Why do we use that? We use that for intubation, but we also use that, as I will tell you later, during recovery, especially in cats or small breed dogs that have this danger of bronchospasm. What we can do is that we can either inject or leave some drops of lidocaine in the carina. And if you put that in the carina, then you have less danger of having bronchospasm and less danger of having an after endoscopy, a post endoscopy, severe coughing and spasm, as I said. Okay, so not only to the vocal folds, but during the recovery phase, we can put some lidocaine also in the carina. And another step essential for bronchoscopy procedure is oxygenation. Okay. In rigid scopes, is there any restriction in pre-medication agents we can use? Most, hi, Asimina. Most of the agents that my anesthesiologist use are the ones that I have mentioned. I have no experience with any other agents. If you have in mind any other for the induction period or for the pre-medication agents that you can use, if you have anything else in mind, write it down and I will ask my anesthesiologist, okay? So that I can give you an update on that. If you use something else other than the anesthetics that we have already mentioned, write it down and I will send you a personal email. But most of the agents that we're using are the ones that I have already mentioned and in the dosages that I have already mentioned. Okay, if you have anything else in mind, drop a line, drop even in the chat box, and I will ask my anesthesiologist even now, and he will give us a feedback. So ventilation in rigid bronchoscopes is achieved by the Venturi effect. Do any of you know what the Venturi effect is? So this is injected oxygen down the tube through the endoscope that entrains the airflow through the endoscope. But unfortunately, this cannot be done in this cannot be done. Okay, Doxapram, I'm very, very happy that we have all these amazing questions during that. I have used Doxapram for laryngeal paralysis, but sometimes it causes tachypnea, Doxapram. Okay, so atropine, I wouldn't use anything that has atropine in endoscopy procedures, in bronchoscopy procedures especially, because this actually dries the mucosa. Atropine dries a lot the mucosa, and we could have a lot of tachycardia. But Kamal, I will definitely ask the anesthesiologist about your suggestion, and I will tell you. Because we don't use Doxapram plus atropine. I don't know if you have used it in this kind of procedure, but we don't use that. It doesn't mean that it cannot be used, but I would try to avoid atropine in these patients, okay? Due to the mucosa, due to the dryness of the mucosa that they cause, and also due to the tachycardia that these agents might cause as well. But I will ask and I will tell you as well. So this is not possible. The Venturi effect, unfortunately, is not possible in the flexible endoscopes. So when should I withdraw? Whenever your anesthesiologist says that you withdraw, then you leave everything, even if you are ready to take a very, very good biopsy sample, or if you already have your cytology sample, you have to withdraw and do it on a later stage. So the anesthesiologist is advised, of course, is consulted by the pulse oximetry. So he sees the pulse oximetry, and according to the indications in the pulse oximeter, he suggests that you should withdraw or not. And what do I do to increase my intubation, my time for bronchoscopic intubation? What do I do in order to increase the time that my working time actually without the ET tube? What I do always is that I put the endotracheal intubation and I ventilate with 100% oxygen 5 minutes before and after bronchoscopy. So this has reduced the risk of hypoxia. And I do that every time, not for 5 minutes, but every time I withdraw and I'm ready to go in again and I re-intubate in order to oxygenate, I just leave it for 1 minute, of oxygenation. You need patience with these patients. Okay, so you will oxygenate the best as you can, and you will not get in unless the oxygen is at least 95%. Now that we were at the zoo and we were scoping the chimps, most of the chimps had a very, very low oxygen rate, because we were going through the ET tube, and of course we were obstructing the ET tube, so their oxygen could be like 82, 83. This is very, very dangerous. You definitely have to withdraw and reinsert after you have Asimina, I will go into that. After you have your oxygenation up to 93. These induction agents, yes, for G and pre-med, you use methetomidine, opioids. Yes, yes, definitely. Asimina says, if you all read at the chat box, Asimina says that we will need huge doses of a single agent, like propofol, for example, and they suppress the respiratory system. They do suppress it. This is why you definitely have to have an anesthesiologist up to effect. But once you extubate, what is your other options? What are your other options? Okay, once you're intubated, or if you can do your bronchoscopy procedure through the scope, through your ET tube, then that's okay. But what about how do you maintain your anesthesia if you extubate, if you have to extubate? This is one thing. And the second thing is, what do you do when your, for example, patient starts coughing? So you have to deepen your anesthesia. All of these agents compromise the respiratory rate and the respiratory tract. And all of these agents are used in patients that have an already burdened respiratory tract. This is the problem with these patients. This is why you have to have a very experienced anesthesiologist. Jason, I would like you to leave the chats, the messages on the chat box, because other people might actually see what's going on the chat box as well.
Okay.
Okay, and as we said in the, yes, sorry?
Yes, I mean, they can find the chat in the answered box. They can find it.
Yes, because I have them erased here.
No, it's
Oh,
not
you have
erased.
them
It's
answered.
just
Okay, you have
go
them
to the
answered. Okay,
answered.
good. Thank you. Okay, and what about the recovery? So we've done the procedure, and we will go into later in the procedure. We've done the procedure, and this is, you can see, what do you see here? What can anyone see here? What is this yellow fluid in the trachea? So this is a normal trachea. You see the tracheal rings, you see the carina, you see the left and the right bronchi. And what did you see in this patient? You saw gastric content. This was gastric fluid. And I will play it again. Can you see the gastric content here? So why was that? Because we extubated. This was for another procedure, but we extubated very, very early. So please, during the recovery period, what we can do is that we can either instill 1% lidocaine in the carina, as I told you before. This is optional. It's not something that you should do as a standard operating procedure, but this is optional in patients that you are really scared that might have bronchospasm later on. Okay. Keep the endotracheal tube in place, oxygenate, and you remove the ET tube as late as possible. Otherwise, you might have hypoxia, you might have gastroesophageal reflux disease and a gastroesophageal reflux of gastric contents into the trachea. Okay. And this is very fresh. This is why you're not seeing any other lesions in the lungs, because this just happened. We extubated very early and gastric content went into the tracheal. lumen. Okay. You can always use tributaline, especially in cats. This is lifesaver. And what about the use of dexamethasone? I know that many of you use Kemal, I'm going to show you how you can place the ET tube and the endoscopy together, but only large breed and giant patients. Okay. I know that a lot of you, whenever you finish with the procedure, what you do is that you do an IV dexamethasone, or for dogs that are branchicephalic, that cough a lot, that have tracheal collapse and underwent and had undergone endoscopy, bronchoscopy procedure. I know that you have it as a standard procedure to use dexamethasone. Please, when you use it just dishes in the right way, in a very, very rational way, because if you have any other bacterial component, this might cause a problem. And in general, we definitely need to use our corticosteroids with a rationale behind it. Okay, don't do it as a standard procedure, only in high-risk patients. So this was during the recovery. This is during the recovery phase. Okay. And this was not a patient with respiratory disease. I just scoped it to see what was going on, why the oxygen dropped tremendously right after my procedure. Okay. And this is a good way to see how a normal bronchoscopy looks like as well. So you have the carina. We're going to talk about it in stages as well so that you can see. And the dorsal tracheal membrane, as you saw. And I tried to see, but of course, all the other gastric content has gone into the lungs. So, and some pooling there in the trachea showed me what it was. How do we achieve oxygenation? 3 ways of achieving oxygenation. Repeated intubations. Unfortunately, there's no other way in cats and small breed dogs. An endotracheal catheter inserted alongside the bronchoscope. I don't like this. It should be a smaller size, and I don't really like it without the balloon, the endotracheal cuffs without the cuffs, actually, the endotracheal tubes without the cuffs. And what we can do is an ET catheter, meaning a urinary catheter, is more appropriate, or a suction catheter is more appropriate. And I will show it to you how we do it. Very, very small in size that can go alongside your scope and can give oxygenation. And your ET tube, in case you have a large breed dog or a swivel connector. So these are the urinary catheters. The urinary catheters or the suction catheters, we need them with side holes as well, not only with the end tip holes. Okay, and this is how we put them in the trachea, and then side ways I can proceed my scope. Okay. And Kemal, these are the swivel connectors. This is how we can put the ET tube and the endoscope together. Okay, and I will show you how this is connected to your scope. There are different kinds of T-adapters. They're called T-adapters if you want to find them, swivel connectors or elbow connectors, okay? But you always missed a part of the trachea that you definitely have to see later on. And this is how the scope is going through the connector. And at the other end, we connect the anesthesia, the anesthetic machine. Okay. And what is our ideal bronchoscope? The ideal bronchoscope for our patients is the outer diameter from 3.5 to 6 millimeters. In giant breeds, we can actually use our bronchoscope as well, our gastroscope as well, the 8 millimeters, but in giant breeds. I tend to use from 3.5. Now, ALHA has a new endoscope of 2.8 millimeters, correct, Jason? This is the new diameter?
Yes, and the working length is 1 meter.
Great. And the working length is 1 meter. So the ideal bronchoscope is between 3.5 to 6 millimeters, with the best ones, the best range ranging from 2.8, that we have the new one, up to 4.5, 5 millimeters is the range of bronchoscopes. I will not go into video versus fiber optic, definitely video bronchoscopes nowadays. If you only have one gastroscope and you want to do of 8 millimeters, of 9 millimeters, and you want to do bronchoscopies with that, you cannot do it. And even if you have, even if you use the 6 millimeters gastroscope for bronchoscopic procedures, please be careful, because bronchoscopic procedures should be not aseptic, but they should be clean procedures. They're not like gastroscopy procedures. And I don't want to put in the lungs the scope that I have put into for colonic procedures or for GI endoscopy. Okay, keep a separate one for bronchoscopic procedures. Unfortunately, this is a clean procedure and you will need a different scope. The biopsy channel should be at least 1.7 millimeters and the working length more than 60 centimeters. Most of ALHA scopes are 1 meter scopes and even longer. And you will need a suction as well. This is how we have put in my practice the scopes. We have created a certain area with all the scopes and the biopsy forceps that are dedicated to this scope. Okay, and I always keep them hanging, not in the suitcase, in order for my scopes not to be stretched. And also, you see that I have removed all the suction buttons and the air button, the air water button, because I want them to dry and dry hanging. Okay. And another thing that really amazed me, and ALHA scopes had it in their human scopes, and I hope that at some point we can have this technology, is the rotating, is the rotating scope. Once we take our biopsy forceps in, it's very difficult to rotate them if they're not rotatable biopsy forceps. So with this technology, with having a rotation control ring, especially in the lungs, and especially in bronchoscopes where sometimes I don't have a 4-way tip deflection, they're not gastroscopes, I always have 2-way tip deflection, up and down. So this is really, really helpful, as you see, because I can rotate outwards, outside the scope, and align my scope with the lesions. This is very smart, and I hope that we can have it soon in our vet scopes as well. And sometimes we have these single-use sterile bronchoscopes, which are really, really expensive. And to be honest, single use for our patients, even if it's not single use, is not a good idea. But I had to give you an overview of those as well. Many companies have single use ones. There have some advantages, that they're totally sterile, that they're ready for immediate use, that they have no repair cost, but their cost is really high and it's not worth it for a single use, or even for a restricted times usage. Okay, you better have your own scope. You better clean it yourself and have it for a lifetime. And what about the endoscopic accessories? I think that we're over our time, but I will finish with the endoscopic accessories, and then we will go next time to the BAL procedures and to the lesions that we see in our patients, and to some interventional procedures as well. So biopsy forceps if we decide to do biopsy in our respiratory patients, then it should be with a small, of course, biopsy forceps. The biopsy channel vary, as you see, from 1.8 to 3.7. Most of the times in bronchoscopy procedures is from 1.7 up to 2.2, maximum 2.8 in giant breed dogs. Okay, I use the round ellipsoid caps without spike, definitely rotatable or not, I don't mind, but with fenestration, because it doesn't smash my sample. It doesn't destroy my sample. So round or oval ellipsoid, even better. Fenestrated, rotatable would be preferable if we don't have this ring to turn to the rotation that we want. Okay. What other endoscopy accessories we need for bronchoscopy? Cytology brush, balloon dilation for tracheal stenosis, injection or aspiration needles. Okay, and BAL traps. Do you know the usage of the traps? The traps, the specimen traps, are used in order to have a totally sterile BAL gathered in this trap through our endoscope channel, through using our suction channel. This is for the endoscopic taking of the BAL. This is for the endoscopic procedure of retrieving BAL, not for the blind one. Okay, and we use the traps because then you can just send off the whole trap for cytology. You can send the trap for it's totally sterile, and you can send it for culture as well. And this is how it is actually, it's connected to your endoscope. From one side, it is connected to your endoscope, and from the other side to the suction channel of your endoscope. And from the other side, it is connected to the suction. Okay. Purchase these traps. A lot of companies have them, and it's very easy to use them. But your channel, your working channel, has to be sterile. Okay. Other endoscopy accessories are the tracheal and the bronchial stents nowadays. A lot of companies have also tracheal and bronchial stents. You see that the tracheal stents and the bronchial stents are different than the others, than the esophageal ones, for example. They have this opening at the edges, at the two edges. The first one is a tracheal stent, and it's from 8 millimeters to 18 millimeters diameter. And of course, the length is tailor-made. There are different sizes, different chart sizes, according to what the lesion is, to how big the collapse is, for example. And these are bronchial stents. These are all nitinol stents. The best stents for lower respiratory endoscopy or for tracheo endoscopy are the nitinol. The usage for the lungs is the nitinol stents. Okay, and we also have the marking catheters. You can see the catheter in the X-ray. Okay, and this is a 5 French catheter. It has a straight tip. Some marking catheters have an angled tip. Don't use that for bronchoscopy. And to actually, these markers are used to, these are placed in the esophagus, and they are used to actually define the size of the stent that you might use. Okay. And the whistle wire is the hydrophilic guide wire that we use in order to put the mark catheter into the esophagus. Okay, these markers, as you see, have 1 centimeter space apart, and they help us measure the length of the stent that we want. And if you purchase one of these markers and you send off the X-ray to one of the companies that sell stents, they might even guide you in which stent size and length to purchase for your patients. So this is a very, very helpful tip and mode. And there are other stents like the J-shape or the Y-shaped for the Carina. And these are some silicone stents that are used in humans, but I wouldn't suggest those. These are actually these J-shape and Y-shaped are AUHA stents from human medicine, but there are also out there Y stents for our patients. And some of them are tailor-made from companies that actually produce stents. So I would suggest that if you have a patient that has tracheal collapse and bronchial collapse, you do both. Because the mistake that we're doing, most of us, is that we don't do a CT scan prior to our bronchoscopy procedure. So this means that if we have a tracheal collapse diagnosed, then we send off the patient for a tracheal stent. But if there is a bronchial collapse as well, then this patient, even after the tracheal stent, will keep on coughing, and the owners will be very, very dissatisfied. And the bronchoscopy procedure, helpful tips. And I will stay here. I will show you the maps. And next time we'll go step by step into the bronchoscopy procedure. Helpful tips is that you really should be cautious about intubation and extubation, because it might cause traumatic laryngotracheitis, and it's very common. Unfortunately, it's very common. Don't use lubricating gels. Don't use lubricating, because I've seen a lot of you use lubricating gels. It interferes with cytological examination. The animal is unable to cuff the material up, especially cats. Cats cannot cuff this material, the lubricant, up. It may plug the airways. And also, don't use topical preparations containing tetracaine or benzocaine, because it could cause oxidative injury and methaglobinemia afterwards, okay? And always use a bronchoscopy map. I always stick a bronchoscopy map in front of my monitor whenever I do a bronchoscopic procedure. It's very helpful. Always do your bronchoscopy procedure after the examination, your radiological examination or your CT scan. And the order of examination will be larynx with very, very light sedation without intubation. Then we intubate, oxygenate for 5 minutes with 100% of oxygen, and then we proceed into doing the bronchoscopy examination, cervical and thoracic trachea. If the tube is on, the cervical trachea will be missed, okay? Then the carina, and then the right side, cranial, middle, caudal, and accessory lobes. The radial cranial arises separately, okay? And then the left side, cranial and caudal. You always have a map to orientate yourself. And this is my bronchoscopy map. Print it and have it in your examination room, okay? And I try always to write down from which place I take a biopsy, for example. And this is my bronchoscopy map for cats. Okay, it's a bit differentiated, but you always have to have the correct map for the patient that you're having in front of you to scope. And this is a normal tracheobronchoscopy. And 1-year-old dog, you see, this is the dorsal membrane. This thick membrane that actually orientates you. Okay, some people have it at hour 12, some people have it at hour 6. And then you reach the carina, and what you do most of the times is that you reverse. If you have a two-way steep deflection, you reverse and go up and then down. If you have a 6-millimeter gastroscope, for example, specially designed for bronchoscopies, then you don't need that because you have a 4-way steep deflection, and you can do either way. You can deflect your tip whenever you want to go, and you go the further in you can, the further in you're able to go. Okay. And once your patient is hypoxemic and cyanotic, then you have to withdraw and reinsert, as we said. And we're going to talk, I think that we're ahead of our hour. I'm going to stop here. Next time, we're going to talk about sample collections, about BAL, about balloon dilations in the trachea, and I'm going to show you some things about stents as well. Jason, are there any other questions up to now? Up to what we have said? It's a huge, huge section, and I try to keep it with details so that you can have a guide whenever you want to do it for yourself. So we will have a part 2 as well, and even a part 3 if you need something more specific. Next time, we're going to talk about sample collections. We're going to talk about many interventional things as well.
Yes, if you have some question. Yeah, there's coming question.
Okay, Ketan, I'm going to write down all your questions about anesthesia, and I'm going to forward them to my anesthesiologist. Ketamine we definitely use. I don't know if it can be used with midazolam in combination with midazolam for endoscopy, I mean for bronchoscopy. But I'm going to write it down, Jean, and I will definitely ask my anesthesiologist and come back to you. Ketamine plus midazolam. Okay. Thank you too. Is there a possibility of using 1.9 Flex XC to perform bronchoscopy? A 1.9, it depends on your patient, on the size of your patient. In which size of patient do you want to use it? In which size of patient, Esma? Thank you, Esmina. Thank you for attending, and I'm really grateful to each and every one of you. We will talk about more perplexed things next time, but for those of you who are just beginning, I just wanted to take it from zero. Okay. Esma, if you want oh, I guess it might work. Yes, definitely. So the 1.9 actually is very, very small. You can have it. My point is that 1.9 can only work for patients like, small kittens or very, very small puppies, small breed puppies. Why I'm saying that? Because you might do bronchoscopy as a diagnostic bronchoscopy, but you might not be able to take samples because your instrument is very, very small. Even if you wanted to use not a flexible one, but a rigid one for tracheal only endoscopy, then it should be at least 2.7. Okay. This is what I mean. You might see things, but you might not be able to take your samples, to take your sample collection. Only sideways and only brush cytology, maybe, but sideways. And this is not good to take sideways collections. Your sample collection should be through your scope. Thank you very, very much. I would like also to announce that we will have hands-on respiratory endoscopy workshop in Cyprus with AUHA in Cyprus on the 7th of April on Sunday. And unfortunately, I missed some of the attendees left. So 7th of April, Sunday, we will have an endoscopy workshop in Cyprus. We will write it in the chat box and maybe send it with an email. There are very few places left. I think that there are only 3 or 4 places left for the workshop. So whoever is interested, please send us an email and we will give you more information about that. And I will be very, very happy to see you in live, in person, each and every one of you. And of course, we will send you the link for the recorded session.
Yeah.
And check our, when is the leopard going to be announced? The case with the leopard, with the tiger.
Yeah, it's I think maybe next week we are.
Okay, and check
checking.
also AUHA YouTube channel, because we will have we have a lot of cases uploaded that you will encounter in your clinics. More perplex, some of them more often encountered, but check about this one because you will be surprised.
Yes, this is a very special one.
Okay, and I have to get back to Jean about ketamine and midazolam. I'm asking the anesthesiologist now.
Okay. So thank you for your time and thank you for all the attendees. And if you are interested in our monthly webinar, you can get more information from our social media like Facebook, Instagram, and the YouTube channel for some study, some cases, and some other information. And you will receive the next webinar invitation by email. And don't worry, we will mention you for the next part. Okay. Thank you, Dr. Lastiki. Thank you
all very much.
attendees.
Thank you.
Yeah.
Thank you.
Thank you
Have
all
a
the
nice
questions.
evening.
Yeah.
Bye.
So today we are finished. I look forward to see you next time. And thank you, Dr. Katrina. And the next time, Katrina will be the main host. I will be the assistant.
And we're very proud of Katrina because she's a vet as well. I'm not saying anything about you, Jason. You know that I'm very, very favoring you, but a vet is always a vet. He's one of the family. Welcome, Katrina.
Okay. Yeah, I'm very looking forward to the next session. Yeah,
definitely.
I think this topic is I also very interested, and I learned a lot. A lot of details. It's good.
I'm very happy.
Thank you so much.
And this is how it is supposed to be, actually. It's supposed to be a very detailed guide from step 0, not for only the advanced endoscopists. We will build it up.
Yes, that's very good. Okay, so thank you all the guys. See you next time.
Thank you.